This schematic outlines two very different cognitive reactions to a perceived threat. On the right is an adaptive human threat model. A person worries they left the stove on, checks it, and the anxiety resolves. On the left is the pathological loop of obsessive-compulsive disorder. The threat triggers an action, but instead of resolving, the feedback loop tightens and the cycle accelerates. The cycle begins with an ego-dystonic intrusion. The patient recognizes that the obsessive thought, whether it's a fear of contamination or a sudden violent impulse, is alien and excessive, yet they are entirely aware it originates from their own mind. To alleviate the crushing anxiety generated by that intrusive thought, the patient executes a compulsion. For a brief moment, the neurological tension drops. This creates a strict diagnostic boundary. A true compulsion brings temporary relief from distress, but it provides absolutely zero pleasure. If an action yields even brief satisfaction, like a compulsive shopper buying a new item, or a hoarder feeling joy from collecting another object, it belongs to a different class of impulse control disorders. In OCD, the patient desperately wants to stop the behavior. They repeat the action solely because of a severe sensation of incompleteness. If a ritual isn't performed until it feels just right, the anxiety rapidly scales back up, forcing the patient to execute the compulsion again, often for hours. Because this mechanism operates entirely differently from generalized anxiety, treating the OCD loop requires clinicians to abandon standard psychiatric protocols. Compulsions are not always visible. Frequently, the actions are entirely covert, manifesting as mental rituals, like repeating a specific internal phrase to prevent a feared outcome. These hidden compulsions pose a severe clinical threat. A physical ritual, like washing hands repeatedly, eventually encounters social friction or physical limits. Mental rituals face no such boundaries. Without external constraints, these mental loops multiply rapidly. A patient can perform thousands of mental rituals a day while sitting completely still, cementing the pathology deep into their daily cognitive function. To navigate this hidden pathology, clinicians rely on the Yale-Brown Obsessive-Compulsive Scale, or YBOX. This 10-point scale isolates the exact severity of both obsessions and compulsions. Establishing a baseline YBOX score is mandatory before writing a single prescription. Without it, a clinician has no objective way to measure if a treatment is actually weakening the mental loop. Uncovering covert rituals and locking in precise metrics provides the clinical justification needed for the extreme pharmacological interventions that OCD demands. A frequent clinical error is confusing OCD with obsessive-compulsive personality disorder, or OCPD. While they sound similar, their neurobiological drivers are completely distinct. A patient with OCPD finds their rigid rules and perfectionism egosyntonic. The behaviors align with their self-image and bring a sense of order. The OCD patient experiences their rituals as ego-dystonic torture. Another diagnostic pitfall occurs when obsessions escalate into what look like delusions. Untreated OCD rarely transforms into schizophrenia. If fixed delusions appear, it is usually a misdiagnosed psychotic debut that was present from the beginning. Misidentifying the root pathology leads directly to prescribing the wrong class of medications, wasting months of critical treatment time on drugs that cannot penetrate the true condition. Achieving absolute clarity on the specific phenotype is the only way a clinician can avoid the trap of artificial treatment resistance. This vertical flowchart illustrates the three-tiered neurotransmitter hierarchy for escalating OCD treatment. We target serotonin at the base, dopamine in the middle, and glutamate at the top. The baseline rule for the first tier is stark. Standard clinical dosing used for major depression or generalized anxiety will categorically fail against OCD. Clinicians must push SSRIs to supratherapeutic levels to achieve the massive serotoninergic impact required. We target escitalopram at 30 to 50 milligrams, fluvoxamine at 225 to 300 milligrams, and sertraline at 250 to 400 milligrams. These numbers routinely push past standard label guidelines, forcing a break from conventional prescribing habits. Pushing specific SSRIs, particularly escitalopram, to these extremes introduces heightened cardiovascular risks, including severe arrhythmias. Clinicians must actively monitor cardiac function. Despite these risks, the data is definitive. Underdosing is the leading cause of clinical failure in OCD management. This graph maps out the latency protocol, a rigid time frame that clinicians must adhere to once maximum tolerable doses are achieved. Doses must be steadily titrated upward over a period of 4 to 6 weeks to reach the necessary threshold. Once that high dose is reached, there is a strict requirement to hold it for a minimum of 8 to 12 weeks before evaluating its efficacy. Long after the drug's serum levels peak in the blood, the actual neurobiological adaptations required to weaken the corticostriatal feedback loop are still slowly forming. If a clinician grows impatient and switches the medication at week 6 because they don't see results, they guarantee treatment failure and artificially label the patient as treatment-resistant. If the patient reaches the 12-week evaluation mark on a maximum dose SSRI and shows a complete lack of clinical response, we step off the baseline. The algorithm shifts to a tricyclic antidepressant, clomipramine, targeting a highly specific window between 150 and 250 milligrams. Transitioning to this drug introduces severe pharmacokinetic hazards. If the patient is switching from certain SSRIs, the interactions can be devastating. Clomipramine must categorically never be combined with fluvoxamine or fluoxetine. These specific compounds aggressively compete in the liver, leading to toxic accumulations that trigger severe cardiac events, drug-induced seizures, and fatal serotonin syndrome. Clomipramine is an exceptionally potent tool for SSRI-resistant OCD, but its volatile profile demands extreme clinical precision. If a patient exhibits a partial but ultimately insufficient response to the serotoninergic baseline, we do not switch drugs entirely. Instead, we trigger step 3, dopaminergic augmentation. We supplement the SSRI with specific low-dose neuroleptics proven for this application: haloperidol, risperidone, quetiapine, and aripiprazole. Haloperidol proves uniquely effective when the OCD pathology is complicated by comorbid motor tics. Conversely, clozapine, while highly effective in schizophrenia, carries an explicit contraindication here. It can paradoxically exacerbate the patient's obsessions. If dopaminergic augmentation fails, step 4 targets the corticostriatal pathways directly via glutamatergic modulation, utilizing memantine at 10 to 20 milligrams or lamotrigine at 100 to 200 milligrams. The data also explicitly lists interventions to avoid. Evidence-based trials prove that buspirone, lithium, benzodiazepines, and standard electroconvulsive therapy are entirely ineffective for OCD. Navigating this precise, tiered algorithm prevents the chaos of blind polypharmacy and ensures interventions remain targeted and surgical. Setting accurate clinical expectations is mandatory. Achieving absolute, symptom-free remission in OCD is highly improbable. Clinical success is defined by a significant reduction in Y-box scores, bringing the intensity of the intrusions down far enough to restore the patient's functional autonomy. Once that stability is reached, the maintenance timeframe is non-negotiable. The effective dose must be sustained for a minimum of 1 to 2 full years. Premature discontinuation almost certainly results in a devastating relapse. Worse, patients frequently return to a refractory state, where the medication that previously saved them no longer works. Maintaining sustained pharmacological pressure is just as critical as finding the right molecule in the first place. When the 2-year maintenance period concludes and the patient has achieved long-term stability, the off-ramp must be executed with agonizing caution. Standard psychiatric tapering schedules, dropping doses week by week, will shatter the stability of an OCD patient. The math requires exact limits. Clinicians reduce the total dose by 10 to 25%, holding that new dose for 1 to 2 months before stepping down. This mathematically rigid tapering schedule prevents the sudden chemical shock that reignites the corticostriatal feedback loop. Pharmacotherapy does not cure obsessive thoughts. It chemically weakens the neurological loop, prying it open just enough so that behavioral therapies like exposure and response prevention can actually take effect. By strictly adhering to this tiered, high-dose, and long-term architecture, clinicians can systematically dismantle the machinery of obsession and return control to the patient.